Good afternoon, everybody. It's nice to see a full hall here. It's nice to be part of this. I see Dr. Umang. I thank Dr. Umang and Dr. Manisha for getting me here and talking to you all. Essentially, what we have done is we have tried to bring in our interesting cases here. We all know that looking at such kind of varied presentations, you get confused in your clinical practice. What are we dealing with? If not recognized early on, it always can lead to significant visual morbidity as well as at times loss of an eye. So it's very important to have a prompt diagnosis and methodical way of examining these cases. To begin with first case, this clinical case presented, he's a 46-year-old male who presented to us for an opinion. He presented with redness, pain, watering and loss of vision dimness of vision in his left eye since 1 month. He also gave a history of accidental spillage of hair dye into his left eye. You can see the clinical picture here. A very discrete kind of a lesion located into the temporal part of the cornea with some spotty appearance here. He was found to be on artificial tears 3 times a day, tobramycin eye drops mixed with dexamethasone combination drops twice a day, and moxifloxacin eye drops. Moxifloxacin eye ointment once at night for last 15 days. He was treated by a primary ophthalmologist. So the question is, what do we do now? How do you describe these lesions? Can we have a quick question here?
That a foreign body?
Clinically, one would think that probably this is looking like a fungal or with a feathery appearance. If there are some patchy infiltrates here, maybe a satellite lesions here. It's a flat-looking lesion actually. And this story is going on for last 15 days. The patient was also on steroids.
Cardia?
Yeah, you got it right. You nailed it right. So what do we do? The first important part is we do a microbiological workup. We ask for grams, TIMSA and 10% KOH wet mount, as well as because clinically we thought a possibility of a nocardia could be there. It could have been a fungal keratitis, or it is possible that this wreath-like pattern is very peculiar of nocardia. You can see a small, infiltrates arranged in a small, round or oval-ish pattern, which is very peculiar of nocardia. So we asked also for a Zee-Nielsen and acid fast stain. And a direct inoculation was done on blood agar, chocolate, potato dextrose agar and non-nutrient agar plates. So what did we get? Like as you can see here on the gram smear, it reveals presence of gram-positive cocobacilli and filamentous branching rods on gram stain. Earlier it was believed that nocardia is a group of fungi, but now it's proven that they are gram-positive organisms, bacilli, and that's why they appear sometimes have a little appearance of on the smears as cocobacilli many a times, and the pathologist or a microbiologist get confused between the other bacilli. On the 1% acid fast stain, you can see them to be like multiple thin pink rods, though the picture is not very clear. It doesn't appear to be very pink because of the poor stain, but you can see them as pink, multiple thin branching beaded filaments. They would be beaded very peculiarly. And here also you can see the beading of these filaments. So it is very peculiar to pick them up on the microbiological examination. However, there was no growth in the culture media from that patient's eye. When you examine these patients on the 10% KOH, you would be able to differentiate between a fungal filament as well as this. These are very thin, small filaments as compared to the fungal filaments. This is a comparison. And this is, though there was no growth, I just brought in a picture here to just show that on the blood agar it would look like growth of small, white, tiny colonies which could be chalky white. They could be raised or many a times glabrous, or there could be powdery appearance, and this is very peculiar of nocardia steroids. So we started him on amikacin 2% eye drops, that is 20 milligram per ml, hourly during day and 2 hourly at night, and oral analgesics were given for symptomatic relief. And as you can see here, the infiltrate has started clearing up and almost healed with a very small, thin, superficial stromal scar. So these were the lesions resolved completely by 3 weeks of a treatment. This is another example of a similar kind of a case where a 32-year-old lady presented with pain, itching, redness of the eye for 15 days. There was no history of trauma. She was found to be on low-dose topical steroids for past few weeks. It's very peculiar that they would be on treatment for a little longer period of time. As you notice here, like there is a double like ring kind of a pattern here. You can see this very peculiar ring with patchy infiltrate at the peripheral part of the cornea. So the micro workup revealed presence of nocardia on smears. This is the clinical picture after the 4 days. So she was put on intensive medical management in terms of amikacin 20 mg per ml drops, and she was also put on other adjuvants, as you can see here. But here I got this here because we started withdrawing these 45 drops much faster, and we got these lesions again here. That's why I brought this again, that it relaxed as the drops were tapered fast. So the message here is you have to be very slow in tapering these 45 drops. So again the medications were stepped up, and a careful and frequent follow-up was necessary for this patient, and finally she resolved with a thin superficial stromal scar here. If you look at the predisposing factors, the corneal trauma was the most common predisposing factors in many of the series presented from southern India, almost in 93.55% of the cases, and most of the time it was soil and sand. 83.87% of the patients with nocardial keratitis were already on some or the other form of medical treatment. The presentation was delayed to 1 week to 2 weeks to 3 weeks of the presentation. There were also isolated case reports of nocardial keratitis with contact lens wear, and even post-LASIK has been reported. So although nocardial keratitis is believed to be a rare entity, a high index of clinical suspicion is very important, and based on that you can ask for microbiological workup, and probably you will be able to reach to the diagnosis. Traditionally, previously, sulfa group of drugs were used for this condition, but now the treatment of nocardia is quite well established with aminoglycoside group of medications, and they respond very well to that. So the clinical pearls here would be early diagnosis can be helpful for effective management of these cases. The current therapies with fortified amikacin and newer fluoroquinolones, quinolones are as effective, and provided the diagnosis is done very much in time. And ongoing research toward rapid diagnosis using various molecular techniques seem to be promising for these cases. We'll move on to the second case. This gentleman presented with history of redness, watering, foreign body sensation and dimness of vision in his right eye for past 10 days. He denied of any systemic illness. There was no history of trauma, etc. And his uncorrected visual acuity was 624 part. And you can see that dilation was almost in the peripheral part of the cornea. This was the presentation to us. He was already on following treatment when he presented to us. He was already on 45 C4 in eye drops 2 hourly, moxifloxacin 2 hourly, tobramycin eye drops 2 hourly, natomycin 5% eye drops 2 hourly, and cyclopentolate eye drops twice a day. This was started probably without a microbiological backup by the primary ophthalmologist. So obviously we wanted to find out what is it like, is it infective or is it non-infective. So we went ahead with microbiological workup, and we found out that there were presence of GPC, gram-positive coca, and few fungal filaments on the smears. Obviously this patient was already on antimicrobials like antibacterials as well as antifungals. So what did we do? We continued the same management but intensified the frequency of the management, and also added oral medications for the symptomatic relief as well. But to our surprise, on the second day of the management, what we see is rather than patient improving, we saw that the lesion had increased despite the management. So we were just wondering that it was a clinic. Can I have a minute? So there was a clinical dilemma whether we are dealing with UK with systemic, any of the systemic vasculitis, peripheral ulcerative keratitis, or is it a viral peripheral ulcerative keratitis with secondary infection of bacterial and fungal. So we did systemic workup for this patient, and it turned out to be within normal limits, except the ESR was 25 mm by first hour. We added topical galifloxacin and topical antiviral, thinking that it could have been a peripheral UK secondary to viral infection with secondary bacterial and fungal infection. On subsequent follow-up, as you can see here, the ulcers start behaving better. You can see that the edges have become grounded, and the infiltrate is also much less. In between also, like, we considered the smears because we realized that over a period of time, again we felt that this area was showing marked, and gutter-like appearance. On repeat smears, we found that there were only GPs and no fungus, so the antifungals were withdrawn and only the antibacterials were continued. But we felt that probably he was not responding to kefazolin, so we changed the antibiotic to vancomycin. So this was at 2 weeks present, 2 weeks of the treatment. As you can see, the ulcer has started healing, but then we started seeing some hypertrophic changes on the epithelium and SPKs on the surface. Maybe probably we are dealing with medicamentosa because of the excessive medication. So we reduce the frequency of the antimicrobials, stepped up the lubricants. And acyclovir was also withdrawn after 3 weeks of the treatment, topical. Then now the patient is only on maintenance dose of antimicrobials in the term of getafloxacin 5% eye drops, topical lubricants. And as you can see here, eventually the ulcer healed very well. So this is how it progressed from this level to this, and then eventually, like change of medications, it responded to both the antiviral as well as the antimicrobials. So it's also known that herpes simplex keratitis is also misdiagnosed as rheumatoid arthritis in many of the cases. So we have to rule out whether there is it any PUK is because of any systemic involvement or is there any viral infection. So there are many reports on that. So the take-home message in this is, in managing infective keratitis, treatment follow-up examination is a must. And many a times you can repeat the smears to find out what are you dealing with. One should rule out systemic causes in these marginal keratitis, and one should keep a high index of suspicion in atypical presentation of ulcers. With that, I think I would like to end my presentation. Thank you very much.